بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the next lecture in the series of diagnostic radiology in English, and here we are discussing the issue of intracranial inflammation and infection. Actually, we will handle the topic in these items. Number one, the congenital intracranial infection, encephalitis, cerebritis, granulomatous infection, fungal and parasitic infections. Finally, we will have some information about the HIV infection. First of all, we should know that whenever we are going to diagnose intracranial inflammation and infection by CT or MRI, and we should inject contrast media. And the contrast media is essential in the differential diagnosis of different issues of inflammation and infection. And we have two main broad findings. Number one is meningeal thickening and enhancement, which is usually diagnostic of meningitis, as you can see here in this axial T1 weighted MR image after contrast. Then whenever you got a lesion with the marginal enhancement of uniform thickness, and you assume you are dealing with an abscess. Then to start the discussion, we'll have first to discuss the congenital and the neonatal intracranial infection. And you only know the classic torch infections, which include the toxoplasma, the rubella, the cytomegalovirus, and the herpes simplex type 2. All these inflammatory conditions usually present by what's known as intracranial periventricular calcification. And as you can see in this example, where you can see minute foci of calcium seen in this axial CT image without contrast, distributed non-symmetric in the periventricular area. And whenever you see this appearance, you assume you are dealing with a congenital intracranial infection, one of these four categories. Then we should know that the toxoplasma and most of the viruses, except the herpes simplex type 2, are usually transmitted through the blood by hematogenous transformation. Then the herpes simplex type 2 is usually transmitted in the birth canal, and most of the bacteria are transmitted by the ascending infection. And there are some of the rules which are not that firm. These rules usually say that the calcium, whenever it is relatively away from the wall of the ventricle, distributed mainly in the basal ganglia area with periventricular distribution, you may assume the possibility of toxoplasma. But if the calcium is intimately related to the ventricular wall, meaning that it is mostly subependymal in location, then you may assume the possibility of cytomegalovirus infection. However, in many cases, you are not sure about the distribution of the calcium, and you see some of these widely distributed calcium throughout the brain parenchyma in this CT images, and you say that this is most likely the congenital intracranial infection, one of the previously mentioned torch inflammatory processes. And toxoplasma is a protozoon which is usually transmitted to cat, then to the cattle, then to the human. And if it is transmitted through the food, it will result in acquired toxoplasma infection, which will affect the chest. While if the protozoon is transmitted to the human, then through the placenta, then it will result in congenital toxoplasma, which will present mainly intracranial. And Toxoplasma gondii is the protozoon which is usually occurs as an acute infection during pregnancy by the bloodstream, as we have said. And if the infection is occurred in the first trimester, it will result in abortion in 17% of the cases. In second trimester, fetal death occurs in 25% of cases, while late in the third trimester, 65% will have subclinical infection, and they will present by intracranial calcifications. Then 10% of the newborns will have hepatosplenomegaly, jaundice, together with the CNS manifestations. And the CNS manifestations include the presence of calcium around the ventricles, as you can see, and sometimes you have hydrocephalus, which is usually assumed to be due to associated aqueductal stenosis. And this is periventricular, extensive periventricular calcification. And you may see that calcium is present in the basal ganglia as well as in the subependymal area. And here you can see dilatation of the ventricles, and this patient may have also Dandy-Walker syndrome. Hence, you can see a retrocerebellar CSF containing cyst, which is continuous with the fourth ventricle. We will discuss this in full details in the lecture of hydrocephalus. Then the treatment of this protozoon is usually by antibiotics. And the cytomegalovirus is one of the herpes viruses, and it infects every person at some times of his life. And the infected pregnant woman will transmit the infection to the fetus, and the infection occurs by bloodstream through the placenta. In these cases, intracranial calcification will also be present, and in many cases you can see that calcium is intimately related to the wall of the ventricle. And here you can see calcific foci that are related to the wall of the ventricle bilaterally, and this is the manifestation of all the torch infection, particularly the cytomegalovirus, where calcium is related to the ventricle. One should know that these minute periventricular calcification may not appear in the MR images. As you can see in this female child, 2 years old, with proven cytomegalovirus infection. The CT scans showed multiple periventricular calcific subependymal foci, and the MRI done on the same day showed no evidence of calcium. And you can see that very minute foci of dark signal in the T2 weighted image may contribute to some of these calcific foci seen in the CT scan. And this is the case of cytomegalovirus infection, where you can see calcium in the region of the genu of the corpus callosum and also in both cerebral hemispheres. In this case, the calcium is not intimately related to the wall of the ventricle. Once more, you should know that calcium, which appear clearly in the CT images, may not be seen at all on MRI. And you can see here foci of subependymal calcification along the ventricular wall, which are not seen in this T2 weighted image or the FLAIR weighted image. Then we came to the issue of encephalitis, and the encephalitis usually occur in patients who are immune suppressed. And different causes of immune suppression includes the HIV infection, malignancies, and the patient with organ transplant receiving immunosuppressive drugs. Encephalitis is usually caused by viruses, and it will result in many intracranial changes. Number one, affection of the meninges will lead to meningitis. Affection of the brain parenchyma lead to encephalitis. And some forms of encephalitis are the ADEM, which is acute demyelinating encephalomyelitis, and the subacute and the chronic encephalitis. Then encephalitis clinically present by fever and headache, and too many other clinical presentations like lack of energy, dizziness, nausea and vomiting, photosensitivity, a change in personality, memory loss, confused speaking, hallucinations, delusion, and unusual behavior. Then encephalitis and the CT scan and MRI has no specific imaging findings. Actually, you only see multiple hypodense areas in the CT scan, and these areas will appear of low signal in the T1, high signal in the T2, and the flare. And if you inject contrast, in both CT or MRI, you may got no enhancement or minimal chiral pattern of enhancement, which is almost similar to that occurs with infarctions. And you see here, this is the CT scan and the MRI showing areas of low signal. And you should know that some of these lesions may show chiral enhancement, and also some of the lesions may contain hemorrhage. And this is a patient with HIV infection, and there are some areas of low signal in the T1, high signal in the flare, and high signal in the T2 weighted image. If you inject the contrast, you expect no enhancement. Then herpes simplex is one of the viruses responsible for encephalitis. There are two main types. Type 1, which is very common, represents about 95% of the cases. This is transmitted non-sexual through the hematogenous spread and usually affects the children and adults. But the fatal type, which is type 2, is rare. 5% of cases sexually transmitted through the birth canal. It causes neonatal encephalitis, and this will result in death in about 80% of the cases, and the remaining 20% may show severe brain damage. Then herpes simplex is the most common fatal encephalitis in the childhood and adult patients. Biopsy is not usually needed since imaging is diagnostic, because this type of viral infection usually affects the temporal lobes, especially the medial part of the temporal lobe. It may occur bilateral or unilateral, symmetric or asymmetric. Then you see here, this is a unilateral case of herpes simplex encephalitis, showing the typical location in the medial part of the temporal lobe. The infection usually show low signal in the T1, high signal in the T2, and if you inject the contrast media, there is no enhancement. And this is a case of herpes simplex bilateral medial affection of the temporal lobes, showing high signal in the flare image. And this is the unilateral herpes simplex encephalitis in the left temporal lobe, showing hemorrhage. And this is the CT scan showing a hemorrhagic focus here and in an area of hypodensity. In the T1 weighted image, and you can see the hemorrhagic focus of high signal and surrounded by low signal area, which turned to be high signal in the T2 and a high signal in the flare image as well. And in this image, you can easily appreciate the presence of a second lesion in the opposite temporal lobe, but is a relatively smaller one. And this is the pre-contrast and post-contrast CT brain scan of a patient with encephalitis, and you can see a hypodense cortical and subcortical area with minimal chiral pattern of enhancement. But the MR images, especially the diffusion weighted image, shows restricted diffusion, and it clearly demonstrated another lesion in the left lobe, which is hardly seen here in the CT scan. And this is also a case of herpes simplex encephalitis affecting the left temporal lobe. There is some swelling by a lesion which is of intermediate signal. It appeared high signal in the T2, high signal in the flare with restricted diffusion. And if you inject the contrast median, you expect minimal chiral pattern of enhancement. Then patients with encephalitis, after subsiding of the acute attack, they will present by both encephalitic sequelae which appear in the CT and MRI as extensive areas of brain damage representing encephalomalacia. There may be severe atrophic brain changes. Also, you may see calcium in the meninges and also like this one, and also in the brain parenchyma. Extraaxial collections may be also present, either inflamed or non-inflamed. And this is what we call post-encephalitic sequelae. There is complete brain damage. You see extensive areas of hypodensity due to encephalomalacia affecting both cerebral hemispheres, sparing only the thalami and the minimal brain tissue around the ventricles. Then we came to the acute demyelinating encephalomyelitis, which is one of the encephalitis series. And in this case, you see similar to any pattern of encephalitis, there are multiple patches in the brain, hypodense in the CT scan, low signal in the T1, high signal in the T2, and the flare. If you inject the contrast, the lesions will not enhance. But how can you differentiate this pattern of acute demyelinating encephalomyelitis from the rest of encephalitis cases? And first, you should know some issues about the clinical picture of these patients. Early in the disease, they present with headache, drowsiness, and fever. Later in the disease, neurological deficits, seizures, and maybe even death. Then you see this is a patient with acute demyelinating encephalomyelitis. The FLAIR image shows large patchy areas of high signal distributed throughout both cerebral hemispheres. The lesions may affect the cortex, but commonly they are located in the white matter. And this is the follow-up obtained 1 year later, and you can appreciate the partial regression of the lesions. This lesion is, in many cases, simulates the multiple sclerosis, and being located in the white matter, showing most of the criteria of MS. But you know that MS is a multiphasic disease, but this acute demyelinating encephalomyelitis is a well-known monophasic disease. MS, the lesions are relatively smaller compared to the lesions with ADAM, and the MS involves the white matter mainly, but ADAM can affect the cortex as well. And the lesions of MS are more symmetric, and the relapsing and remitting course is one of the characteristics of MS. Then acute demyelinating encephalomyelitis will show multiple foci in the white matter, sometimes in the cortex, low signal in the T1, high signal in the T2, and high signal in the FLAIR, with no enhancement after contrast injection. And you can spot the diagnosis of ADAM by a typical history of the patient, which is a history of recent vaccination or a flu-like attack within 10 to 15 days before the attack of ADAM. And you see here, these are low signal lesions in the white matter, high signal in the T2, and high signal in the FLAIR. And sometimes you got enhancement in ADAM lesions. Then we came to the issue of meningitis. Any meningitis can be caused by viruses or bacteria or granulomatous lesions. And meningitis may result in hydrocephalus, which is the communicating obstructive type. May cause dural sinus thrombosis, may result in subdural or epidural empyema, may extend into the brain parenchyma, leading to abscesses and infarctions, and may reach the ventricle with inflammation of the ventricle will result in ventriculitis, or what's known as epididymitis. Then for the diagnosis of meningitis of whatever etiology, you should inject the contrast media. And this is the pre-contrast scan and the post-contrast scan area. you can see that the sylvian fissures are obliterated by relatively hyperdense lesions, and you see the dilated ventricles, the lateral and the third. Whenever you inject contrast media in, you can see enhancement in the sylvian fissures, enhancement in the basal cisterns, and enhancement along the dura. Then you can easily reach the diagnosis of meningitis. And this is the T1 post-contrast axial MR image showing enhancement of the basal cisterns around the midbrain and the enhancement of the adjacent brain parenchyma, and also enhancement through the sylvian fissures with considerable obstructive hydrocephalic changes affecting the lateral ventricles. You can see the temporal horns are markedly dilated. Also, the third and fourth ventricle are also dilated. Then here is a patient with meningitis, T1 weighted image before contrast and T1 weighted image after contrast. You can see enhancement along the tentorial leaflets, enhancement through the cerebellar folia, enhancement in the cistern around the midbrain, and enhancement in the sylvian cisterns as well as in the suprasellar cistern. And you can easily appreciate the dilatation of the temporal horns reflecting the state of hydrocephalus. And sometimes you got enhancement of the meninges as well as enhancement of the brain parenchyma, what we call meningoencephalitis. And in this category, whenever you have the diffusion weighted MR images, you'll see the brain parenchyma, inflamed brain parenchyma showing restricted diffusion. And in the contrast enhanced image, you will see leptomeningeal enhancement as well as patchy enhancement within the brain parenchyma. As I have said, the meningitis may lead to dural sinus thrombosis. Then you can see here that this is a non-contrast CT scan. And whenever you see the vessels in the non-contrast CT scanning, you know that this is acute thrombus, exactly similar to the hemorrhage. When the blood stops the flow inside the vessels, it will show similar density exactly when it stops inside the vessel. Then this is the region of the vein of Galen, which is also thrombosed, and this is the region of the internal cerebral veins, which are thrombosed. Then the venous sinus thrombosis will result. Also here you can see some hyperdensity within the superior sagittal sinus, and you know that the CSF is absorbed by the arachnoid villi and drained into the superior sagittal sinus. Then if the sinus is occluded, you will got hydrocephalus of the obstructive communicating type. Here you can see the dilated ventricles with periventricular edema due to retrograde transependymal CSF fibrillation. And you know, venous sinus thrombosis is one of the complications of meningitis. And in order to see the inflamed meninges, then you have to inject the contrast media. Then, as a sequelae of meningitis, pus may accumulate outside the dura, resulting in an epidural elliptical shaped collection with enhancing margins representing an epidural embolism. And you know, a collection or blood in the interhemispheric fissure or along the tentorial leaflet should be in the subdural space because there is no epidural space here. Then you remember when I said that subdural hemorrhage can occur within the interhemispheric fissure or along the tentorial leaflets because there is no epidural space here. Also, pus can accumulate, and we can see enhancement of the margin, and this is diagnostic of subdural embolism. And this is an epidural abscess or epidural embolism. In a patient with meningitis, you see little meningeal enhancement, and you see the marginal enhancement of the collection. And whenever infection reaches the ventricle, you got what's known as ventriculitis or ependymitis. And the diagnosis is easy whenever you see that the ventricular wall is thickened and enhanced, and at that time the ventricle has turned into an abscess or a bag-filled of pus. And you can see here thickening and enhancement of the ventricles, which are severely dilated, representing a case of ventriculitis. And this is a case of meningitis. You see a leptomeningeal enhancement and this T1 weighted contrast enhanced MR image, and this is the T2 weighted image. And after regression of the attack of meningitis, the patient may develop sterile subdural CSF collection known as subdural hygroma. And you know that this is sterile collection by the absence of enhancement. If you inject the contrast media, the sterile collection or the hygroma will not enhance. Okay, we have finished the topics of congenital intracranial infection and the issue of encephalitis and the meningitis. Then we came to the third issue, which is the cerebritis. And the cerebritis is different from encephalitis, as encephalitis is caused by viruses, but cerebritis is caused by bacteria. Then bacteria are usually transmitted to the brain through the ascending infection or the hematogenous spread. And penetrating trauma may help also to introduce organisms into the intracranial space. Also, septic emboli from congenital heart disease may have a role. Then early bacterial cerebritis is difficult to be diagnosed. In the end, you can see only a lesion, which is hypodense in the CT scan, and low signal in the MRI. And if you inject the contrast media, it will not enhance. And this is the post-contrast T1 weighted image. This is the flare image, and this is the diffusion image. Because inflammation usually shows restricted diffusion, and you can see the restricted diffusion here. But the diagnosis is quite easy whenever the lesion liquefies and forms an abscess. In the early stage of cerebritis with just the brain parenchymal inflammation, it is difficult to be diagnosed, and you may need sometimes to biopsy the lesion to assess the possibility or to exclude the possibility of a neoplastic lesion. But late cerebritis and after the abscess formation, and you got a marginally enhanced lesion surrounded by a perifocal brain edema, and the lesion is of low signal in the T1, high signal in the T2, and it shows uniform marginal enhancement, and very characteristically you got restricted diffusion in the inflammatory lesions in general. And in order to differentiate, sometimes you may have a glioblastoma multiforme, which may simulate an abscess, and you may got help by the diffusion weighted images as well as the MR spectroscopy to differentiate. Then brain abscesses may be unilocular, may be multilocular, may be multiple with a major one and satellite lesions. And usually they show marginal enhancement of uniform thickness, and they are surrounded by variable degrees of brain edema with variable mass effect. And the posterior fossa abscesses may have relation to the ear infection, and one of the tricks in the examinations is the cases like this, and you forgot to look to the vitreous bone for signs of infection or inflammation, which may contribute to the etiology of the cerebellar abscesses sometimes. And this is the classic appearance of a cerebellar abscess with uniform marginal thickness. And if you look carefully to the ear here, and you see some abnormal signal denoting infection. Then the abscess in the early stage, about 2 weeks, will have a thin enhancing rim, and later on the margin will be thick. And this is the cerebellar abscess showing a thick enhancing margin with little perifocal brain edema and considerable mass effect on the fourth ventricle with consequent supratentorial obstructive hydrocephalic change. And this is the classic appearance of the brain abscess in the T2 weighted image, T1 post-contrast, and the diffusion weighted image. And here you can see the restricted diffusion. In the contrast enhanced image, you see the classic marginal enhancement of uniform thickness. Complications of abscesses: number one, the development of satellite or daughter abscesses. And you see this is the big abscess with two daughter abscesses nearby. And this is another brain abscess in the opposite hemisphere. The infection may spread to the ventricle, resulting in ventriculitis and ependymitis, or may extend outside, reaching the meninges, leading to virulent leptomeningitis. And this is an example of brain abscess in the temporooccipital area, ruptured inside the ventricle. And you see enhancement of the ventricular wall on both sides, denoting the development of ventriculitis or ependymitis. Now, I have said that ventriculitis is an easy diagnosis whenever you see that the ventricular wall is thickened and contrast enhanced. And most of the cases with ventriculitis are usually secondary to surgical procedures, and less commonly from rupture of the brain abscess or meningitis. And this ventriculitis is uncommon, but a serious disease, and inflammation of the choroid plexus inside the ventricle may result in abnormal enlargement and enhancement. And this is a case of ventriculitis, as you can see, thickening and enhancement of the ventricular walls. Then we came to the granulomatous infection, and here we want to discuss TB and the sarcoid. Actually, you know that TB is now increasing in intracranial TB, I mean increasing in the developed countries due to the HIV infection and the intravenous drug abuse, as well as the immune compromised states, considering cancer and the patients with organ transplant. And the introduction of the TB bacilli intracranial may result in tuberculous meningitis, tuberculous encephalitis, and tuberculomas or tuberculous abscesses. The meningitis is similar to any other form of meningitis. There are diffuse leptomeningeal thickening or thickening and enhancement of the basal cisterns, as you can see around the ventricle, and you see here and there. And in order to specifically diagnose this as tuberculous meningitis, you should see some tuberculomas inside the brain parenchyma. Then you know that this is tuberculous in etiology. And the tuberculomas are exactly similar to the small brain abscesses, or what is known as buttonhole appearance. You see, this is a classic appearance of tuberculoma. It is similar to a small abscess with thick enhancing margin, but the contents are usually relatively hyperdense due to the caseous material inside. They are not containing liquid pus like bacterial abscesses. And this is the multiple brain tuberculometer by CT showing the typical appearance. And you can easily appreciate the buttonhole or the ring, the thick enhancing ring around these lesions. And most of these lesions are small and surrounded by variable amount of perifocal brain edema, reflecting the activity of the disease. And here is the typical appearance of intracranial tuberculometer, showing the classic buttonhole appearance with variable degrees of surrounding perifocal brain edema. This is MRI post-contrast T1 weighted image, show multiple tuberculometer in the brainstem, in the cerebellum, in the temporal lobes, showing the classic appearance of tuberculomas. Whenever the tuberculoma is big, like this one, we may call it the tuberculous abscess. And these are the classic appearance of tuberculomas, and this is the tuberculous abscess. And you remember that abscess may contain relatively hyperdense material representing the caseous material. And here you can see multiple tuberculous abscesses and the tuberculoma together with subdural empyema in the left frontal area. Also here you can see typical basal meningitis due to TB because of the presence of multiple tuberculomata here. And you know that the basal meningitis may result in vascular thrombosis, and this vascular thrombosis may result in ischemic changes around the area affected by meningitis. And here, this is the cause of this high low signal intensity lesion in the temporal lobe, which represents an ischemic area. Then we came to the sarcoid, and the sarcoid is a well-known non-caseating granulomatous infection, and its exact etiology is unknown. And the patient with sarcoid may have CNS involvement in 5% of cases, and this will affect mainly the cranial nerves, as you will see. But you should remember, in up to 50% of patients with sarcoid they are usually asymptomatic. And whenever you see sarcoid, intracranial sarcoid, you may got associated pulmonary infection in more than 90% of cases, which usually supports the diagnosis of intracranial sarcoid. Then the chest manifestations will be discussed in full detail in the thoracic part of these lectures. But in order just to know, the sarcoid is usually diagnosed by bilateral, almost symmetrical enlargement of the hilar lymph nodes, together with the presence of interstitial reticular shadows in the lung fields, as well as minute nodules scattered, which are better seen by the high resolution CT scan. While intracranially, the neurosarcoid can affect, or usually affect, the leptomeninges and the subarachnoid space. It can also affect the region of the hypothalamus, which is more common than affection of the brainstem, than affection of the cerebral, than affection of the cerebellar hemispheres. Also, perivascular infiltrative involvement of the Virchow-Robbins spaces is one of the criteria of neurosarcoid. Solitary or multifocal lesions, which are dural-based, may simulate meningiomas in some cases, and you can see some T2 hyperintense lesions in the periventricular area, as I will show to you. But this is one of the manifestations of sarcoid intracranial, which is considerable thickening and enhancement of the meninges, what we call pachymeningitis. But this is not classic for the sarcoid. It can occur in many other diseases, but one of these diseases is the neurosarcoid. Then you see here an injection of contrast in this T1 weighted MR image, and you see leptomeningeal enhancement in the cerebellar folia, as well as in the basal cisterns around the brainstem, as well as in the suprasellar area. This leptomeningeal enhancement is not specific for sarcoid, and you reach the diagnosis of sarcoid by the clinical history and other imaging findings, especially in the chest. And the leptomeningeal enhancement have a long list of differential diagnoses. Also, the pachymeningitis, like this one, thickening and enhancement of the meninges, may be due to meningitis, may be due to sarcoid, may be due to leptomeningeal metastasis, may be due to diffuse meningioma, and may be due to histiocytosis. And as I have said, in order to reach the diagnosis of sarcoid, you should know that the patient clinically is known to have sarcoid disease, or you should have intrathoracic manifestations to help you for reaching the diagnosis. Then we came to the fungal infection, and you know that fungal infection and also the parasites infecting the CNS are usually uncommon, and many times the patient is one of those who are immune compromised. Similar to any organism, the fungus may produce meningitis, encephalitis, granuloma, or abscess. And the meningitis is similar to any form of meningitis, just diffuse meningeal thickening and enhancement. How can you know that this is the secondary to fungus? You cannot know. And this is just meningitis or whatever etiology. But if you see some parenchymal lesions, and these parenchymal lesions are classically of low signal in the T2 weighted image. Look here, and in this T1 weighted image, you see lesions of intermediate signal in the temporal lobes. In the T2 weighted image, you see jet black lesions. And after contrast enhancement, you got an extensive enhancement in this lesion. The dark signal in the T2 weighted image is highly suggestive of fungal infection. And this is the case of fungal sinusitis that has extended intracranial. And the T1 weighted images show intermediate signal. In the T2 weighted images show very dark signal of the fungus. And after contrast injection, you got evident contrast enhancement of the fungal lesions. Then we came to the parasite, which is the most common CNS parasitic infection is the cysticercosis, which is caused by the Taenia solium. And this parasite goes inside the body through the contaminated food and reaches the brain tissue but through the circulation. And the embryo, whenever it reaches the brain tissue or the meninges, will cause intense inflammatory reaction with the formation of capsule. Then the larva dies and calcifies. Though we have an active form of cysticercosis and a dead form of cysticercosis. In the active form, you got a lesion which is almost similar to the tuberculoma, with a thick enhancing margin surrounded by edema, but very typically you should see a nodule inside this cystic lesion, which is known as the cyst and the dot sign. If you see this, and you can diagnose cysticercosis in most of the cases. Whenever the organism dies and it calcifies, it will result in multiple periventricular calcific areas, which may simulate the congenital intracranial infection. Then you should add the list to the list of congenital intracranial infection, the torch, and you should add cysticercosis as well as a cause of periventricular calcium. Also, you should add TB, healed TB, to this particular group of lesions. And here you see the typical appearance of cysticercosis, which is a cyst with a dot sign. And in MRI image, you see a cyst with a dot sign. Even you see only one cyst with a dot, and the rest of the cysts do not contain this dot, you should diagnose this as cysticercosis. And this is the classic appearance of cysticercosis by CT. And here you see the cyst with the dot sign, the cyst with the dot sign, and one cyst only with a dot inside is enough for the diagnosis of cysticercosis. And this is the cyst with the dot sign, cysticercosis, CT without contrast and CT with contrast, and you see the marginal enhancement and you see the dot inside. If you do not see the dot inside, you cannot diagnose this as cysticercosis, and you may diagnose this as tuberculoma. And here the cysticercosis with a dot cyst and the dot sign in the CT, cyst and the dot sign in the MRI, and this is very clearly seen in the T1 and the FLAIR weighted images. And this is the patient with lesions where you may be able to see the cyst and dot sign somewhere, like this one. Then you go to the diagnosis of cysticercosis. If you cannot appreciate this, you will diagnose these as tuberculomas, and you will not be so much away from the right diagnosis. Then we go to the calcified neurocysticercosis, what we call the starry scar, and many periventricular calcium, which is similar to the rest of congenital intracranial calcification. and this is healed cysticercosis, which should be included in the differential diagnosis of periventricular calcification. One of the parasites inside the brain is the hydatid cyst. And the hydatid cyst is an intraaxial lesion. We have discussed it in the intracranial cysts, and it's usually unilocular with fluid density on CT and MR. If you inject contrast, it will not show any enhancement. It may show calcium in the wall and is not usually surrounded by perifocal brain edema. This is an example of hydatid cyst in the CT scan, and this is an example of hydatid cyst in the MRI T1 weighted image. Then finally, we came to the manifestations of AIDS inside the brain. And actually, the manifestations may include a direct effect of the virus itself in the brain parenchyma, or being a major cause of immune compromise, then it will result or allow many of the opportunistic infections to go inside the brain. Also, some of the neoplasms may be, especially the lymphoma, which is well-known neoplastic lesion in the immune suppressed patients. Also, the drug-related complications. If you look carefully here and see a lesion which is marginally enhanced, surrounded by extensive area of perifocal brain edema, anyone may call this as an usual abscess of bacterial etiology. But knowing that this patient is an AIDS patient, you should include in the differential diagnosis the possibility of toxoplasma. And these are the opportunistic infections which may be encountered in patients with HIV infection, like toxoplasma, cytomegalovirus, fungal infections like Cryptococcus, Candida, Aspergillus, also TB, syphilis, progressive multifocal leukoencephalopathy, and some of the bacterial infections. You remember that these are tuberculomata, which are a little bit larger than the usual tuberculomas, and you should expect this in immune compromised patients. I cannot say that this is the classic appearance of toxoplasma abscess in the brain, but this is a usual finding in many of the cases. And here in the non-contrast CT scan, you may see edema and you see a faintly hyperdense lesion. After enhancement, the lesion enhances. And this is MRI T2 weighted image, and this is MRI T1 post-contrast. Then the toxoplasma may appear or may simulate the appearance of TB in the brain of an AIDS patient. And you see here multiple marginally enhanced lesions scattered in the periventricular area, and this has been proved to be secondary to toxoplasma infection. Also, the AIDS patients are subjected to the development of early brain atrophic changes and white matter signal abnormalities much more earlier in age compared to the patients who are not infected by the HIV. And you can see this brain for a patient 36 years old, which you can see this appearance in patient over 60, for example, with dilated ventricles, dilated extraaxial CSF spaces, sheets of abnormal white matter signal around the ventricles due to ischemic changes or due to the effect of the virus on the vessels or the white matter. And after you inject contrast media, you got no enhancement. Then in the countries where AIDS is a common disease, they usually say that whenever you are encountered with a lesion in the brain parenchyma, you are in the differential diagnosis between only two conditions, the toxoplasma and the lymphoma. Then the differential diagnosis is not that easy on imaging. You may say that the toxoplasma as an infection will show restricted diffusion on diffusion weighted images, while lymphoma will not show restriction being a neoplasm. Also, lymphoma may have a specific enhancement pattern and toxoplasma may have a different one, and the surrounding edema may be different and so on. But actually, you cannot or they cannot reach the differential diagnosis between toxoplasma and lymphoma unless the lesion is biopsied. And this is the only confirmatory maneuver to differentiate between both, because the treatment actually is different. And here is the pathologically proved large B-cell lymphoma in an HIV patient, and they see the enhancement pattern. You remember that the lymphoma in immune competent patient will show homogeneous enhancement with little surrounding perifocal edema and little mass effect. But the lymphoma in immune suppressed patients will show different behavior. It may simulate the glioblastoma multiforme. But considering the patient with HIV, you should consider one of two, either toxoplasma or lymphoma. Then we came to a lesion which is almost confined to patient with AIDS, and this is the progressive multifocal leukoencephalopathy. And this is caused by one of the viruses which is carried by a majority of the people. This virus is activated when the immune system is, or the immune defenses are lowered. And BML is most common among individuals with AIDS, and BML is rare in other immune suppressed individuals. It's one of the characteristic lesions that can be seen in AIDS patients. From its name, and the progressive means rapidly advancing, multifocal, too many lesions, leukoencephalopathy, abnormalities in the white matter. And then you see here abnormalities in the white matter more prominent on the right hemisphere, and these abnormalities are commonly located in the temporooccipital area in most of the cases, but it can affect any part of the brain. And this is an AIDS patient with a lesion which has the classic anatomic site, and here you can see here high signal in the T2, high signal in the FLAIR, and this lesion does not usually show a contrast enhancement. It will appear of low signal in the T1 and low and also hypodense in the CT images. Finally, we came to some conclusions. First, you should inject contrast media whenever you are doing a CT scan or MRI for the diagnosis of suspected intracranial infection. Whenever you see diffuse meningeal thickening and enhancement, you can diagnose meningitis. And if you see a marginally enhancing lesion of uniform thickness, you can diagnose an abscess. If you see periventricular calcification, you can diagnose congenital intracranial infection, including the toxoplasma and the cytomegalovirus, the rubella and the herpes simplex. Also, you can add to this list cysticercosis and healed tuberculosis. Intraaxial cyst with no enhancement is usually diagnostic of hydatid cyst. Bilateral temporal non-enhancing lesions are highly suggestive of herpes encephalitis whenever the clinical picture can allow this diagnosis, and the enhancement of the ventricular wall is diagnostic of ependymitis. And I thank you very much.